Great.
We are going like 5, 4, 3, 2, 1, shoot.
Good afternoon, everyone. I do hope you're all having a great day. On behalf of ACIOE Associates, I would like to welcome you to our second health webinar on lessons from the COVID-19 epicenters in Nigeria. Today's webinar will highlight strategies adopted at subnational level to curb the spread of the COVID-19 pandemic in Nigeria. Our thoughts and prayers are with those who have lost loved ones in this period. We would like to thank all our participants for taking the time out to be with us today. We also especially thank all our panelists for taking time out of their very busy schedules to join us in our discussions today. ACIOE Associates is an advisory services firm providing solutions in strategy, government relations, regulatory affairs, economic development, advocacy, investment facilitation, and policy analysis. We have supported government, development partners, and institutions to develop sustainable solutions to the challenging economic and development issues within the countries we operate. Our strength as an organization lies in the strategic relationships we have built with key stakeholders in government at national and subnational levels and within critical sectors of the economy, including health, agriculture, energy, fast-moving consumer goods, and human capital development. At the onset of the pandemic in Nigeria, we met with our clients and stakeholders to understand how best to create value for them during this period. Also noting the effect of the pandemic on the Nigerian economy, its communities, and the common man, it became important to streamline our work and ensure that we are contributing to the national and subnational COVID-19 containment efforts. To this end, we began to provide daily updates to our clients and key stakeholders on the effect of the COVID-19 pandemic on Nigeria's social, political, and economic landscape. These updates have helped our clients make quick and effective business decisions during these challenging times. To ameliorate the effect of the pandemic on the health and socioeconomic well-being of the vulnerable population, we have also coordinated the direct distribution of palliatives and hygiene products to underserved communities in Abuja and other states of Nigeria. To support ongoing COVID-19 containment efforts at national and subnational level, we have facilitated partnerships between the private sector and the Nigerian Center for Disease Control, as well as the Federal Ministry of Health. Recognizing the growing importance of sharing lessons from the COVID-19 epicenters in Nigeria, we have decided to host webinars as a platform for states to share unique strategies adopted and lessons learned.
Hi,
Today's
just testing.
Will be the second in the series and will have the following outline. We will begin with a presentation from the ACIOE team on current COVID-19 statistics at national level. Following this is a presentation by Dr. Emmanuel Agogo, the country representative of the Resolve to Save Life initiative. This presentation will provide an overview of the public health coordination between national and state level. We will then dovetail into a panel discussion to be moderated by Dr. Olumide Okola, the Senior Health Specialist at the International Finance Corporation. Our panel today is made up of distinguished speakers who have coordinated and led the COVID-19 containment approach within a number of states in Nigeria. Following the panel discussion will be a question and answer session, during which the panelists will entertain questions from participants. Please feel free to submit your questions via the question icon on your screen. After the session, Ekene Nisiche, the managing partner ACIOE Associates, will give the closing remarks. The webinar will last for an hour 30 minutes. Once again, we thank all of you for your time and we look forward to your questions. I will now hand it over to Doyin to continue with the webinar. Thank you very much.
Thank you so very much, Bami. That was just a very wonderful introduction. My name is Adedoyin Adelekon. I am the data analyst of ACIOE Associates. Today, I'll be giving you an overview of the COVID-19 situation in Nigeria. And over the next couple of slides, I'll be giving you an insight on the COVID-19 situation based on, firstly, the global perspective, secondly, statistics from the top 10 African countries, and thirdly, Nigeria, which currently has 18,480 confirmed cases as at yesterday, the 18th of June, 2020. Now let's go to the global perspective. On this graph, I'll be talking about two key things, which are, one, the Oceania region, which comprises of countries such as New Zealand, Samoa, and Papua New Guinea, has the highest recovery rate of 94%. This was actually achieved as a result of the early total lockdown and instant community testing, which helped to curb the community spread. This was more of a proactive measure instead of a reactive measure. Secondly, I would look at Europe, which has the highest fatality rate of 8%, of which there were two main contributors to this, which were, one, the high level of community spread, and secondly, a high percentage of an elderly population. Now, when we look at the top 10 African countries, we at ACIOE Associates have done a lot of research around the top 10 African countries with the highest number of COVID-19 cases. And this graph shows some of the information gathered. Going forward, I'll be focusing on three major things. One, I would love to bring to your notice that Mauritius has carried out the highest number of tests in Africa, which is 10.14 of its total population. Secondly, Morocco has the highest recovery rate of 88% in Africa, and this is excellent. I would, however, love to point out 5 key things which they did and of which our tiers of government could look into. 1, they decreed a sanitary state of emergency and the country closed its maritime and airspace border until further notice. Secondly, the public, private, and military hospitals increased the intensive care unit capacity from 1,600 to 3,000 beds, of which they continue to welcome their patients in the best possible conditions. By March 3rd, Moroccan factories started producing 3 million sanitary masks a day, with a goal to achieve 5 million by the next week. They also made wearing of masks compulsory and ensured it was supplied at a controlled low price. Fourthly, by the first week of April, Morocco had started manufacturing its own ventilators with oxygen masks, with the first batch of 500 expected that week. These non-invasive ventilators had a capacity of 3,000 hours of use. Also, all Moroccan affiliated to the social security system began to receive up to 200 euros per month extra till the end of June. And by the 17th of June, they had tested over 455,000 people. That is tremendous. Now, looking at Ghana, you will see that Ghana has the lowest fatality rate of 0.5%. It's interesting that I'll bring to your note 4 key things they did. Now, firstly, Ghana decided immediately they located the index cases. They shut down 2 main cities, which were Accra and Kumasi, to better understand how the virus was spreading. Although they kept the restrictions on public gatherings, closure of schools and borders remained closed, that remained in place. Out of the 120,000 people that were traced, Ghana had been able to test 100,000 people. From studying the cases in Accra and Kumasi, the government understood the geographic footprint of the virus and therefore intensified testing and testing machinery in the areas that had been flagged. This was to ensure that the limited resources available to Ghana were channeled to the right places. And lastly, Ghana increased the local production and manufacturing of pharmaceutical industry across the country to satisfy their own needs. Now let's go to our home country, Nigeria. On the left side of the screen, we have the total number of confirmed cases based on geopolitical zones by the 15th of June 2020. The Southwest had the highest percentage of confirmed cases at 52%. This was because they have a high rate of testing, which had uncovered the new high number of COVID-19 cases in the region. On the right side of the screen, we have the ratio of active cases to confirmed cases. You will see that around the 15th of April, when we had the total lockdown, the percentage of active cases dropped by 34% because there was a low rate of community spread. However, the government was pressured to ease the lockdown as a large percentage of our populace are daily wage earners. Looking forward from that day, we can see that it went high, but we started dropping due to the high rate of testing. Now, if we're to go to the next slide, looking at the next slide, on the left side of the screen, you see the current number of test centers in Nigeria. The current number of test centers in Nigeria is growing at an average of 77%. We started at 1, and now we have 38 centers precisely, with states like Lagos having 5, Kano having 5, FCT having 4, Katsina has 1. And lastly, looking at the right side of the screen, the ratio of confirmed cases to total tests. Out of over the 100,000 tests carried out in Nigeria, only 17,000 have confirmed positive for the COVID-19 virus. Thank you so very much for your time. And now I would love to hand over to Dr. Emmanuel Agogo as he gives us his presentation. Thank you.
Good afternoon, everyone. I have the privilege of just speaking from the place of providing previous support to NCDC and still being part of the infrastructure supporting NCDC's efforts. Next slide, please. Next slide. So I work for an organization called Resolve to Save Lives. We are an initiative of Vital Strategies, and we provide technical support to the NCDC, as well as providing in the two areas, just to the country, the area of preventing epidemics. And the second area is really around working with improving management of cardiovascular diseases. I'll be going through, based on previous working with NCDC, just an idea about, the NCDC state engagement strategy, looking at matters arising in the context of COVID-19, especially since we're talking about, what's happening at the cold face at the state level, and then looking at opportunities for improving coordination and interaction from the national level to the state level, specifically in the context of NCDC. Next slide, please. So the NCDC in 2019 developed a state engagement strategy, state engagement strategy, which was to really build states' capacity to respond, prepare for, and detect and respond to infectious disease outbreaks. And there's a lot to talk about when the country doing a JE, a joint external evaluation of how well the country can respond. This was done in 2017 and repeated in 2019. And one of the gaps there was around how well do the states respond, and the need to support the states and look at how the states can respond more effectively. The NCDC bill was passed in December 2018, and the mandate for the NCDC within the context of working as an agency of the Ministry of Health is to actually provide guidance, technical and logistic support to the state levels, as well as looking at what the state sees. The states themselves are responsible for the health sector preparedness, and the state is responsible, because health is on the concurrent list, to make sure that at the state level, preparedness and response is optimal. Next slide, please. Next slide. So one of the first, I will be going through, back one slide. So the states, there are 5 areas of critical support that were identified, where NCDC is meant to support the states for best practice, which if it was in place before now, I guess things might have been slightly different. The first is around establishing what we call public health, state public health EOCs. These are coordination centers where, when you have an outbreak, they are meant to provide the platform for the states to respond to outbreak, to coordinate the response of human, animal, and environmental health using the One Health approach in the context of what's called the integrated disease surveillance response mechanism. So there are 40 diseases There have been 23 more. Next slide, please. Okay, so the other aspect is supporting the states to develop capacity for public health diagnosis. So making sure that each state has its own public health lab. The previous slide is around SOMAS. SOMAS is an electronic, that's number 2 slide. SOMAS is an electronic digital system for tracking cases. So each case that is identified goes into the SOMAS, and you can track it from when you identified him up to the time you get the lab test, and then the platform is being developed to look at case management as well. Next slide. Next slide. And then looking at rapid response teams. So you might have seen people going out to the community and helping to trace cases and finding out where the cases are and helping communities to be more effective. Next slide. And then really one is around coordination and collaboration between the states to make sure that there's shared learning. That was the general vision and picture for the state engagement strategy. Next slide. And so in the long term, NCDC is supposed to help states to develop their capacity to use data better, provide technical support, and have periodic RRTs when you have an outbreak, the state is overwhelmed, you send the team in to support. And then also to provide a strategic stockpile of need of specific things. So in the context of COVID-19, what has been the problem? Next slide. In you've already gone through these slides in terms of, so NCDC set up an EOC on the 27th in response to the outbreak. There are 9 pillars, which you can see on the slides. An incident action plan was developed. But since then, some issues have emerged in terms of what the issues are. One, coordination, the fact that this is the first time, even though the country has responded to Lassa fever, to meningitis, this is the first time that there's an outbreak that is covering virtually all the states of the Federation. So the systems have been stretched. There's a need for more coordination, both at the national level and for the states also to coordinate better. There's also important to look at the data issues and to improve data coming from the LGA level to the state level to the national level for coordination, for purposes, and for use of the data. Then also, even within the national and the state level, this is a coordination of the risk response goes beyond just health sector. You have the airlines involved, you have the socioeconomic impact, you have schools, you have markets. And so it's a more complex scenario that we find ourselves. Next slide. This is just telling you about, even within the state, we know that the non-health sector is involved, the SMOH is involved, the HPCDA has a role, the state EOC has a role, and so all these state structures need to be better coordinated. So this slide just talks about the refocusing, looking at how NCDC went through a process of trying to understand the issues and helping and finding a way to improve response. So improving coordination, improving operational decision-making, looking at proactively, looking at an adaptive response. So we're beginning to see that the response should move from a national level to a more of a state level and to more even of a local government and even to hotspots. So gradually you're seeing that it's a precision epidemiology to really look at where the hotspots are and intervene appropriately. They're looking at making sure that when teams go out of the field, what is their mandate? What is the state mandate? So that there is less of clash and more of coordination. And then improving state scorecards, so tracking, adding a performance management approach. After 6 months, after 60 days into the outbreak, a mid-action review was conducted, next slide, which was to look at best practices in the milestones. All the pillars had input into this. A few states were invited into the discussion to look at what is the progress with the IIP preventment. And I think this is a recommendation that we will also make to the states, that the states also need to think about the process of reviewing their outbreak so far so that you can be more adaptive. Next slide. Next slide. So there are a few strategic directions. One is around making sure that we're suppressing transmission, we're reducing mortality. We're seeing that the mortality, 70% is in old elderly patients and patients with comorbidities like diabetes or hypertension. Mobilizing all sectors and communities and ensure there's community ownership. This is only the one way we can reduce stigma. Reducing morbidity and mortality from other causes. We're seeing that there's a collateral damage collateral mortalities from people not being able to access care. The states have a role in making sure that hospitals are open, services are going on, immunization carries on. Then looking forward, how do we make sure our health system is more resilient going forward? Next slide. So this NCDC as a whole has 5 major strategic directions where the response is now going. And so these will be looking at how do we streamline in terms of the state support, providing more support to the state EOCs, so operational funding support where available. This is being looked at through the mechanism of the Outbreak Revolving Fund that Resolve to Save Lives and the Dangote Foundation has really funded now, and looking at even also the World Bank funding to make it available, to make sure that states have funding for the RRCs, the rapid response teams to go out. The WHO has also done a lot in this area. Harmonizing communication between the lab, make sure information flow is seamless, looking at an adaptive approach, and then supporting state supply chain management so that, you know, good quality consumables and reagents and inputs are going to the states. Next slide. So this is just a broad dimension of support. And what do they state? And this is in the context of the World Bank funding, which should be available to states in a few weeks' time. You know, money for rapid response teams, funding for coordination, funding for funding to roll out SOMAS to some of the states, and then improving risk communication activities at the state level. So I'll stop there, and I'm sure there might be some questions which we can take later. Thank you very much.
Thank you so much, Dr. Gogo, for a really comprehensive overview of what has been going on with the national response. But you know, like we heard from panelists on this same program last 2 weeks ago, we had the commissioners from Lagos, Ogun, and a few other states sharing with us their experiences and to see how several of the things that you described at the national level, how has it really percolated down to the state level? Because that's really where the action is. So I'm going to, what we will do is take a 3-5 minute overview, what's going on in the state, and then we begin to look at some targeted, discussions. So first right out of the blocks will be the Honorable Commissioner of Health in Katsina State, Honorable Yakubu Danja, just to give us an overview, a very short overview of how Katsina has been responding to the COVID-19 pandemic. Honorable Danja, as you can imagine, just yesterday with the statistics we received, 12 new cases in Katsina. Apparently, it seems the pandemic is beginning to really show its face in Katsina. How are you responding to this? Over to you, Dr. Danja.
Thank you very much, Doctor, for the opportunity, and very good afternoon to everyone. In Katsina State, it's not surprising to record the 12 cases we recorded yesterday because of the fact that we have gotten an access to laboratory tests. As you know, we have a new laboratory that gave us an access to quickly take samples and get tested. So it's not a new thing. Actually, I wanted to start by giving you an overview of what Katsina is all about. Katsina is having a population of about 9 million people with a population of 350,000 under 1 year, 1.7 under 5 years, and then under 15 years, we have a little above 4 million. We have 34 local governments and 361 wards across the states with about 17,000 settlements. Katsina State is bordered with Kano, Kaduna, Jigawa, and Zamfara states. And then we are bordered with an international border of Niger Republic. We have 1,736 health facilities across the states. Our own coordination in the states regarding tackling COVID-19 is into some segments, about 4 segments. We have the Emergency Operations Center. We have the Emergency Preparedness and Response Committee, which is chaired by me. And then centrally, we have the Katsina State Emergency Response Committee, chaired by His Excellency, the Deputy Governor. And then the overall leader of the state oversees the affairs and the conduct of all of these 3 committees. We do conduct regular meetings, and then the incident manager is also at the center of these problems. We also wanted to give you what we are doing regarding the response activities based on incident management. And we have some structures regarding coordination, surveillance, case management, infection prevention and control. We have laboratory, we have risk communications and social mobilization. Regarding social mobilization, we were able to sensitize the public. We started with sensitizing the traditional and religious leaders, and then we also went ahead to invite all stakeholders to educate them on ways to prevent against the contact of COVID-19. We also have in Katsina State presently, we have about 420 confirmed cases of COVID-19. And then we recorded 22 deaths. Although these 22 deaths were not in our facilities, most of them are samples taken from post-mortem. Only 4 or 5, precisely 5, were recorded in our facilities. We presently have 398 cases alive. And then in Katsina State, where I mentioned earlier that we have 34 local governments, 25 of them has cases of COVID-19. Next slide, please. Okay, this is regarding surveillance. In surveillance, we have a total of 3,020 contacts, and then we have 229 on follow-up. 2,196 have gone beyond the 14 days follow-up. 295 are now the cases. Regarding case management, we have 5 centers to 6. We have an IDP center which has a capacity of 160 beds, is fully completed with full equipment and fully functional. And then we have General Amadi Rimi Specialist Hospital, also called GASH, which has a capacity of 30 beds. We also have General Hospital Daura, where we have 18 beds capacity. We also have the Federal Medical Center having 12 bed capacity. And presently, work is ongoing in another center called Tashar Bala, where we intend to provide a capacity of 160 beds. And also the NYSC camp is about completion, is going to be launched next week. God's willing, we have 200 beds there. Regarding the laboratory, we have some designated centers where we assign to be taking samples. We have the maternal and child health in Kofar Guga. We have the Federal Medical Center, Katsina, and the General Amadi Rimi. And then presently, there is a collaboration. A memorandum of understanding has been signed between the state and a private laboratory called Sahel Medicare and Diagnostic Center, and that is where we are running our tests. And they are doing very well, giving us results in good time. Next slide, please. Regarding the infection and
Dr.
prevention.
Danja,
Yeah.
Dr. Danja, thank you. I think there's so much that you have to tell us. Let's come back to you. From now, let's move to Kano to hear from my friend, Dr. Tijani Hussein, who was formerly Director of Planning Research and Statistics and now the CEO of the State Primary Healthcare Development Agency. I'm already receiving a whole lot of questions about what's going on in Kano. And I won't ask those questions now. I want you to first give us an overview of how you have responded in Kano, but there's so much interest about what Kano is doing in terms of COVID response. Over to you, Dr. Tijani.
Thank you, Dr. Olumide, and hi to everybody. For Kano, I'm going to give a very short snapshot of actually what has happened and what is happening. Since the beginning of we reported the first case in Kano, a task force was integrated by the governor of Kano, which is headed by the governor, the governor, and this task force was integrated on the 6th of March 2020. And even before that, we developed a multidisciplinary incident action plan, and also we ensure that there is an incident command system with 10 technical pillars. However, one structure did not happen was that initially we had only a task force, but again, look at the number of at which we need to respond. We created what we call the technical team in such a way that the task force itself becomes advisory the one doing the job, they are the one running the technical affairs. And this technical response, we've made it into 10 pillars, ranging from surveillance to safety and security. And as we all know, the first index case was reported on 11th April 2020. And since then, we collected over 8,100 samples. That is as at day before yesterday. And as at now, we have 1,000 because we have on the screen are new. The current figures is that we have 1,170 confirmed cases from the 6 governments. Metropolitan and constituting or had the majority of cases. And right now we have we follow up our contacts and also have 695 studies with 50 mortality. And the overall positivity rate for Kano is around 14%. However, at the last days, our positivity rate has been dropping. We have a positivity rate of only 6.09%. Why the response by the one thing we realized was that isolation facilities cases, however, those are and they need critical care. They need to have a place where they need to be catered for, ensuring that there is adequate infection and control. As such, we created what we call holding areas. These are where we keep such cases. So we have two at the moment. And additionally, we also have support from various organizations, both government and non-governmental, such as INEC, Google Foundation, Amgot Foundation, and several others. Looking at our strategic directions then was how do you improve leadership and coordination, how do you ensure that we do what we call community sampling, and this in 4 days for community sampling we are able to collect over 2,000 samples, and we are planning to step up in all and next phase we will roll out in the next 3 LGAs. And for some collection, we have identified 16 sites to engage public and private utilities for link researches and tracing down knowledge on create awareness among communities and also improve the management and data collection. Is a team to go on the field and take data and take some we also have daily community engaged. We have activities to also have the use of that we know our hotspots that we map. Now, looking at the cases we have, we feel we might not be able to cater for all of them in an isolation facility. So we are adopting the national strategy, and in the next 1 day or 2 days, we are going to roll out full home-based management. And we've developed checklists, we've developed protocol, and also we are utilizing the e-platform where we can all do this. So looking at overall response in Kano, this is where we are in a snapshot.
Okay, thank you very much, Dr. Jose. I think you might need to switch off your video and just go to audio because we are having challenges hearing you. I think there are problems with the internet connection. Thank you so much. So I would have loved to go to Dr. Agogo right now, but let me bring on Dr. Yakubu Danja. Dr. Yakubu Danja, I don't know if you can hear me, but there's something we need to quickly get out of the way. There's a huge security situation in Katsina, you know, and here you are, a health leader, managing and dealing with a crisis like no other, and then you have to, at the same time, be wary of security implications. How is this affecting your response in Katsina State? There seems to be a lot of people who want to know how you are managing this situation, managing the pandemic and the ongoing security situation in Katsina. Dr. Danja.
Thank you very much, Dr. Olumide. It's really quite challenging, even having access to these areas where we are facing this crisis. But one thing we relied on are the disease surveillance officers who mostly are indigene within those localities. They are those helping us to get some little access where possible to fish out some that present with some symptoms of COVID-19, and then those that came from a journey. With them, we are doing some level of work to make sure that we access each and every corner across the state.
Yes, sir. So whilst you're also talking about that, again, the data that we're seeing here in Abuja sees that there seems to be a high percentage of new infections amongst your healthcare workers. So is this a situation of inadequate availability of PPEs, or is it a corollary effect of the security situation, or what? Because here, Katsina in itself already has a problem with the number of human resources for health. If you then have this additional issue of healthcare workers getting infected, it then becomes a double whammy. What are you doing with respect to this?
Yeah, Dr. Olumide is really quite challenging. We have about 35 healthcare workers who are infected with COVID-19, and although over 95% were asymptomatic and already discharged, they are fully back to their businesses. I may say earlier is as a result of inadequate PPEs. But to be honest, the state government has been able to procure some, but despite all that, we are still facing challenges of adequate PPEs.
Thank you so much. I just moved next door back to Dr. Hussein. We need to just clearly get this out of the way. Dr. Hussein, you've shared with us some of the innovations and how you've been able to respond to the pandemic in Kano. But there's a big elephant in the room. In the last 4 to 6 weeks, there were reports of quote unquote excess deaths over the baseline deaths. Has the state government been able to tell us, or have you working with the team been able to identify what was the cause of the deaths? And then how is data through SOMAS informing your response?
So thank you, Dr. Olumide. Yes, around in April, our on social media about and since then we went and did some investigation. We actually conducted a mortality review across Kano, and we've gone to all the we've taken data for 2 weeks, and we've looked at death over a period of a month. That's between 1st April to 2nd May 2020. And what we found out was that before I now go to the finding, when we collected the data, we used we engaged our stakeholders, all those who are deep involved in the process of this mortality review.
Dr. Zeni.
Yes. Yes.
The audio is still hasn't improved. My suggestion is maybe you switch on and off your device. Whilst you do that, let's move to Ekiti. If Ekiti, unfortunately, we've gotten down into the panel session. I'm not sure if we'll be able to take a presentation, but if the Honorable Commissioner, Ekiti State, Dr. Yaya Kolade, I know a lot is going on in Ekiti State, but in 2 or 3 slides, if you can give us a summary of how Ekiti has responded to the pandemic, then we can continue with the flow of the panel discussion. You're welcome, Dr. Yaya Kolade.
Thank you very much. Sorry for joining you guys a little bit late. There's a lot going on in the state today. I've been very busy. Basically, Ekiti State is the 3rd state that had a COVID-19 case in Nigeria after Lagos and Ogun State. And we had our first case was March 18th. And when we had the first young man that came from America, who came to one of our tertiary institutions, and at that time, the definition for COVID-19, the signs and symptoms were not written on, not solid yet. but with good intuition, because the young man was having profuse diarrhea. We were called into the scene when he expired already. We took samples from him and we took samples for his associates. Even though his own sample was inconclusive, but we found out very quickly that one of his chauffeur, the young man that was driving him around, turned out to be positive. And this young man became a force in this case. At the very beginning, before we had our patient, one of the things we did was that because we were in the process from January preparing for Lassa fever, so we were in the process of training and teaching our healthcare workers on universal precautions. Basically, we were training for the body fluids for Lassa fever and all those things. So when COVID-19 came on board, we just switched on to what is next, knowing that this is an aerosol that is dispersed through droplets. We started training, and His Excellency from the task force, I think we had one of the early COVID-19 task force that was initiated in the country. We started gathering everybody together, training, getting our PPE, which we have already secured. Procurement was done before we got our first patient. The issue that was with us was that Ekiti never had an isolation center. So that's where we came in, that at this particular time, we need to have an isolation center. And the first place we decided was a 10-bedded hospital, which we located. And it was located in what is called Obadeju Bay Hospital, which was, it was an establishment already. So this 10-bedded isolation center was where we started. And just to fast forward, when COVID came on board, we increased a total number of beds to 150 beds in Ekiti State. And as we increase, we continue training, educating our healthcare workers, and procurement continue for PPEs, hand sanitizers, and everything that we need. At that time, we started with only 2 patients. Gradually, it's increasing. And we had a case of a woman, a pregnant woman that came from Lagos, that came in during the lockdown. She had cesarean section and had a cardiac arrest. It was after she had a cardiac arrest that a sample was taken. We got a result, she was positive, and we had healthcare workers that were taking care of her that got infected through that process. There were 2 physicians and some other people. So with contact tracing, we started treating those people. They got better. She died because of the cardiac arrest that happened right during the cesarean section. We continue with the management, and as we continue, we had another case of somebody that came from another. We were focusing on infectious prevention, control, and containment. Containment became an issue once we had our first case. So all our propaganda, all our advertisement, all our education, sensitization was based on containment. And containment is something that we started very early by educating our citizens about the prevention, what they need to do to isolate, social distancing, isolating yourself when you are sick, not coming into the community. And I believe very early His Excellency stopped everybody. I think all our employees were out, they were sent home, just allowing only the essential workers to be at work. And that went on for about 6 weeks. And palliative care is another thing that was continued it started very early with the state government. And as it continued, we started having help from the victim support.
Thank you very much. Thank you very much, Honorable Commissioner. That's, again, a comprehensive overview. But a leading question for you, and I would also ask the same question from Dr. Danja. A federation like Nigeria, where you have the central government and the state government, sometimes this relationship works. So you have an NCDC Act. NCDC has said management of COVID is now decentralized to the states. So I will ask you first, then we'll move to Dr. Danja, Commissioner Katsina, to say, states today, where you are sitting as the healthcare leader in Ekiti State, do you and your team have, one, the resources you require, the technical capabilities that you require to actually be able to deal with the pandemic at the state level? So I want you to take this first, and Dr. Danja would also answer this very briefly, please.
Okay, thank you for your question. Basically, yes, in Ekiti State, we were ready, because before the NCDC even pushed it and said the states are in charge now, we've always been in charge. We started preparing, we started educating our people, and resources were made available. Don't forget, Ekiti State has what we call Resource Mobilization Committee, which are sons and daughters and lovers of Ekiti State. This is a committee that was established to support us. We know, because we were not getting much help from the NCDC financially, from the federal government financially. We got assistance from technical support. We were sent people to train us. We have an EOC that was established, and we started from day one with our EOC, and we started training. So when NCDC came on board to Ekiti State, they supported us technically. We have WHO on ground that has been with us from inception, and we just continue. And one thing that I did with my team in Ekiti State is that all tertiary institution was included from the get-go. I mean, the Ekiti State Teaching Hospital, the Federal Teaching Hospital, the Abua Teaching Hospital, and the Hospital Management Board, the Ministry of Health. So it was a collaborative effort. And we had all the good heads that were heading all the pillars. So we were well prepared, and we've been doing it. There was a time when NCDC sent someone to us, and they had to withdraw the personnel because another state needed it, and they, in their words, we were more stable. So
okay,
we were ready.
Let's hear from Katsina. The federal-state relationship. Is it okay? Are you all right with it? Can it be better?
Yeah. Dr. Olumide, thank you very much for the opportunity. I think the relationship between the state and the federal is quite cordial, and I think it's better that NCDC take the leadership of managing COVID-19 so as to have full control instead of allowing everyone to do it himself. That will create some level of abuse. However, regarding capability and capacity of resource, I think we have enough. This slide you are seeing is during the training of healthcare personnel, where we trained over 200 clinicians from doctors, nurses, lab personnel. And then we also trained so many hundreds of disease surveillance officers across the local governments. I think we have the technical manpower,
Okay.
but yeah.
That's fine. So I'll then move to Dr. Agogo, who spoke a lot about, you know, the capacities being deployed from national to state through Resolve, NCDC, and other partners. Dr. Agogo, how can we actually even rapidly scale up the kind of support that is going on to states? States are now currently developing their IAPs. In the next 1 week, they'll be receiving 100 million naira from the World Bank. In another 4 or 5 weeks, they will be receiving a couple of $100 million again from the World Bank. And all of this is dependent on the IAPs. So financing would not necessarily be so much of a problem, but the kind of technical capabilities and diagnostics that goes into the quality of those IAPs.
Okay, thank you very much for that question. One of the things that had happened, actually, just like the Honorable Commissioners said, and congratulations to the colleagues who, for all the work they're doing. I mean, like they've clearly said, at the cold face, you know, their leadership has been exemplary, and I think it's really critical that we acknowledge that. At the very outset of the pandemic, when it was declared, WHO supported all the states to come together, all the state epidemiologists to come together to start developing what we call pre-IAP, so pre-incident action plan, even before they had any cases. And subsequently, no one knew, we kind of expected, but now that there are cases across the whole states, it's moved on to developing incident action plans to address the critical challenges at the state level. One of the things that has happened with the experiences that of responding over the years to Lassa fever, to Ebola, to meningitis, and so on, is that there are critical best buys that we know that really help the states. And part of what the states also did was to do, you know, like a mini gap analysis of what the challenges are. You know, your Honorable Commissioner for Ekiti talked about how some states may not have had, may not have necessarily had isolation centers. The laboratory testing capacity may not have been there, like Katsina has said. And of course, in Kano, we know that even though DSNOs are trained and so on, SOMAs may not be available. That's the e-surveillance tool. So what we should be doing now is to look at those critical gaps, especially in those 5 key areas around rolling out an e-surveillance system, ensuring that labs are working, ensuring that RTs are trained and available, ensuring that risk communication and community engagement activities are functioning, and ensuring most importantly that people who eventually, unfortunately, get COVID-19 survive. So, and the partnership there's a multi-range of partners. AFINET has been involved in training field epidemiologists over the years. So there's a lot of technical capacity in country. And we have clinicians, just like you talked about. And then one other final thing before I hang up is really around IPC. We can't overemphasize IPC enough. So one of the strategies has been WHO, NCDC, a lot of partners have been looking at how do we improve infection prevention and control, not just the lip service of making the things available, but getting the healthcare workers, our colleagues, to use this the knowledge that they get. Over to you. Thank you.
Emmanuel. So I go back to Kano, Dr. Tijani Hussein, just now to address one critical issue that leaders like yourselves would have to face. And I don't know whether we're able to share the slides to show how the delivery of basic services has dropped in the first quarter of this year when we compare that to the first quarter of last year. There's a tool that's able to give us disaggregated data across states. So Dr. Hussein, you're CEO of the Kano State Primary Healthcare Development Agency. What are we doing to ensure continuity of basic services? Honorable Commissioner Ekiti shared with us how a woman with a severe section lost her life. And that probably could scare healthcare workers, you know. But overall, in Kano, how are we ensuring that basic services continue to be delivered? Family planning, immunization, amongst other things. Over to you, Dr. Hussein. Is Dr. Tijani still with us? I think he's muted.
Am I audible now?
Go on, sir. Go on, sir. We can hear you.
Yes. So thank you. Yes, we've experienced around March, April, up till May, we've experienced dip in provision and access to healthcare services in Kano. And this dip is not unconnected to, you know, the pandemic. People are scared, health workers are scared. There is inadequate infection prevention and control knowledge and also materials. To restore confidence and also to ensure that people have services. Otherwise, children would die because they have not been immunized. The catastrophe would have been most and significant. So we ensured that, especially in high volume facilities and also smaller volume facilities, we've provided personal protective equipment appropriate to all the levels. We've also trained healthcare providers on infection prevention and control, because unless they get protected, we might not be able to they might not be able to provide those services. We will also train more than 1,500 healthcare providers on IPC across public, private facilities, and primary, secondary, and even tertiary facilities. Currently, we have trained over 2,400 primary healthcare providers with the support of MPHCDA on provision of services in COVID pandemic. And also we are trying to now reach out to people that services are now back. People can go and access services, and also we are getting our facilities organized to ensure that we provide all the necessary services. Over.
So now let's look at another major theme, and that's one where I think states have really brought to bear a lot of innovation. Katsina, you have shared with us how now Katsina has a molecular laboratory. Not just that, you also have a public-private partnership in play. Ekiti, you have a molecular laboratory. Overall, one of the things Doyin said at the onset of this program is for a country that had 4 molecular laboratories in February, and as of today, we're talking of close to 40 molecular laboratories. This is almost perhaps one of the highest numbers on the continent. But having molecular laboratories to conduct RT-PCR tests is one thing. Churning out the required number of tests is a completely different thing. Today, Nigeria has tested less than 100,000 tests. NCDC has done its part. They've deployed the laboratory architecture. What really is then the problem that we've not been able to test as much as we should? Honorable Commissioner Katsina, in fact, you said the 12 new cases yesterday was a result of now new capacities in testing. So do you want to share some more light on your testing capabilities and how you'll be able to ramp up this number? Because all of this is now in your hands. And we then take the perspective from Ekiti as well. Dr. Danja. Dr. Danja, I think you're on mute.
Okay. Can you hear me now? Hello?
Yes. Yes.
It is important to share with the listeners that Katsina Laboratory has a capacity of testing 270 samples per day. And we also intend very soon to engage about 102 local government rapid response team who were already trained for surveillance. And we also want to establish in each of the local governments a center where we can be able to collect samples so as to have access anytime we want tests from the local government or find out who traveled or who are coming from a journey. We quickly take samples and bring to the laboratory. Presently, we have 34 local governments and we have identified about 30 centers. We want to ensure the remaining 4 also have centers where we can be able to take samples and bring to the laboratory. And,
okay, thank you. So how many, so you have capacity to do 200 tests a day?
Yeah.
270 a day. Are you able to hit that number currently?
Come again?
Are you able to conduct at least 250 tests a day?
Yeah. There was a day we recorded about 260 something. tests in a day. And it's really evident that we can be able to test up to 274. We have tested 260 something in just 1 day.
Okay, and this is different from your contract with Sahel because you share that innovative partnership with Sahel. So, or is the same partnership with Sahel that's able to produce this 270? Because unlocking and dealing with this pandemic is the kind of leadership we bring on board to testing our testing strategy. So the listeners are very keen to know how you're able to navigate increasing the number of samples tested.
Yeah, our memorandum of understanding with Sahel Lab is that is similar to like public-private partnership, where we agreed that for every test that has been conducted, we have a specific amount to pay them. And then they are to provide personal protective equipment to their workers, and they are also to supply the regiments for the tests. This is our agreement with them, and it's working very well with us.
That's really, it's an innovative approach under these clients. And I think I would like to commend your effort on that. I know Ekiti has a similar program in place. Honorable Commissioner Ekiti State, do you want to share with us how many samples are you testing a day right now, since we're in the phase of community transmission? And how are you able to leverage PPPs to scale up the number of tests you're able to conduct?
Thank you very much. It's a good question. Basically, Ekiti State Molecular Lab came on board 2 days ago. So we purchased our own molecular lab. That means we own it. But we have a collaboration with 54 Gene that they will test 10,000 tests within the next 3 months. 10,000 citizens, capability of testing 10,000. And with the RT-PCR in Ekiti State has a capability of 400 samples a day. But in reality, we are thinking between 100 to 200 samples will be tested. We just started the pilot testing, and the pilot testing started in the capital, which was just yesterday. And out of that, we tested the first 10 samples were taken there. It's been done, the result is out. We'll be getting the official result within the next couple of hours. And we started with our healthcare workers. We will be going through the 16 local governments. So in total, we're going to have about 19 sample centers, 3 in the capital and 1 in each local government. Samples will be taken. What our own MOU says with 54 Gene is that they are going to train 8 molecular laboratory scientists in Ekiti State. So after COVID-19, we will still have our laboratory scientists to be able to perform tests and do some other gene molecular work. So basically, we are looking at when we get into full year, we'll be testing between 100 and 200 samples a day from each local government, from all our local governments in a day. But we are not there yet because we just started yesterday. Actually, yesterday was the first time we had sample and testing was done because the NCDC had to come to Ekiti on Saturday to do the accreditation for accreditation purposes, and they went through the lab. But the one good news I want to share on this platform is that Ekiti will soon be having at least another 3 molecular labs coming into this state. Basically, we're going to have 1 in Abuad, 1 in university. Not one. The first one now is currently placed in the teaching hospital in EXU, which is the Ekiti State University. We'll be having a molecular lab. Another one will be coming to one of our polytechnics. So what we are trying to do is that at this time, we'll be more than well equipped, and it's not just for COVID-19. We are looking into diagnosing all other conditions that needs RNA or DNA amplification. So for now, The state is providing the PPEs and everything that is needed.
Okay.
Thank you.
So those labs being put in those institutions, were they paid for by the state government?
No, no. One is paid for by the private institution that owns it. The second one, the VC told me, is from Tech Fund. And the one that is going to the Polytechnic. These are oncoming. They are not ready on ground. But these are paperwork is in place already. But the state paid for this one that is owned by the state, not the other ones.
So just to cool things down, because we were moving at a real fast pace, just to mention that, look, it's important to highlight what is working. What is working thus far from this call and things that we've heard so far. There's a breakneck deployment of testing infrastructure. At the national level, NCDC has accredited close to 40 molecular laboratories. Recall, this was only 3 to 4 by the end of February when the pandemic broke. 2, the states are also taking things into their hands. They've also deployed molecular laboratories in their own state and also utilized the capabilities available in higher institutions in their state. I learned from the commissioner, you are also bringing in consultant specialists available in teaching hospitals, not necessarily even owned by the state, into the response. And I think this is a great thing. Just yesterday, Nigeria became polio-free. So there's a whole lot of good things going on, and this is an opportunity for the health sector to really improve for the better. But we shouldn't wrap this conversation up without spending a bit more time on treatment, case management. Look, like I always say, regardless of whatever number you have, 3% of these people would be critical care cases. They will need to have high level sort of critical care. So, Dr. Hussein, I know that with the numbers you're having now, what is the capability to manage moderate to severe cases in Kano today?
Yes, thank you, Dr. Olumide. In Kano, what we have done from the beginning was to divide our isolation facilities to categories. We have level 1 facility, level 2 facility, and level 3 facility. For level 1 facility, that's where we hold our suspected cases in case they do not have anywhere to self-isolate. They do not have the right environment. Level 2 is where we now hold our moderate, mild to moderate cases, while level 3 we have where we treat the severe cases. And for the severe cases, we have the ventilators, we have oxygen, we have all the necessary equipments needed to manage those needing ICU care. And there is also a linkage between the level 2 facility. We station an ambulance in case that we need to transfer quickly someone who deteriorates. In COVID, what we've realized and what we have seen is that patients can deteriorate very fast. And therefore, we need to have adequate arrangement in place to ensure that we do not experience mortality. Yes, we have, if we look at the statistics for Kano, we have about 50 deaths, but most of these deaths actually occurred outside these isolation facilities. And where we have the critical manpower needed to treat them. Over.
Thank you so much. Just as I asked Katrina Nikiti to also weigh in onto case management. I'm particular. Katrina shared with us the number of healthcare workers that are infected. Thankfully, we know that they've gotten better, but there is that risk at the front line? There's that risk at the front line. Would any of our panelists, Katrina, Ekiti, what are the special incentives put in place for healthcare workers who are on the front line? Without healthcare workers, we can't make progress here. I mean, let's be clear about that. You know, so we've had information about how PPEs have been procured, how IPCs are being put in place in facilities. But look, all of this will be grammar without adding financial incentives. So anything around health insurance for healthcare workers or hazard allowances for healthcare workers? Katrina, then Ekiti.
Hello?
Yeah, Commissioner Ekiti. Sorry, Commissioner Katrina.
Well, just to answer your question, Dr. Olumide, in Katsina State, we have special incentives packaged for the rapid response team and then the case management team daily. We have a token that we do give them daily. Yeah, that has been very usual. We have never failed doing that. And it's also important to tell you that regarding the case management, we also have a holding center of 150 capacity beds. And then across our 21 general hospitals in the state, we are planning very soon to also establish a holding center where we manage patients that are suspected of COVID. After confirming that they are positive, then we bring them to a treatment center. Thank you.
Yes, Ekiti, incentives for healthcare workers.
Thank you very much. Basically, in Ekiti State, where there's financial incentives for the first liner, and there are some financial benefits for our EOC workers, for our DSNOs and our case management people, especially the people that are with the patients 24/7. There is some reimbursement that is done on daily basis and is being calculated. It's an agreed amount and is being given to those patients. And apart from that, about 500 first-line healthcare workers are just being insured in Ekiti State. And that is to insure them for in case of any fatalities or any issues. This is something that came on board during this COVID-19. And the government is looking to increase this capability of insurance to other people. And that is what is going on. And palliatives has been extended too. So, but I know the financial incentives is what is more important to the people. And that is ongoing for the first line workers, not all healthcare workers, but for the people taking care of COVID-19 patients in Ekiti State. Thank you.
Thank you very much. So that's a good segue to, we've been talking about lives in the last hour and a quarter. So Dr. Gogo, I don't know if you want to share with us, you know, now as we move into livelihoods, we simply cannot continue the lockdown. All of this is now being eased. In fact, very soon interstate travels will be allowed. What do you, if you were to look into a crystal ball, are we easing the lockdown too early? I've listened to Dr. Tom Friedman, you know, the CEO of Resolve, talk about this all the time. So as a country rep of Resolve in Nigeria, what is your take, your honest take on easing the lockdown and the struggle with livelihoods? Consider the fact that 80% of Nigerians work in the informal sector. What do you see?
Okay, thank you very much for that question. So I'm going to say a few things, right? And I'm really happy with the way the discussions have gone. The strategy going forward, and I'm so grateful that the colleagues have talked about this, around, you know, tracing, testing people, triaging in the healthcare facility so that we can make sure that it is safe to open up the healthcare system for patients to still receive care. and then treatment, which you've also addressed. So those 4 T's are critical as a strategy going forward. And I'm really happy that we've touched on those. And specifically to the question you've asked, I would talk about the 4 L's. One is about lives. So the lives of Nigerians, the whole response is about lives. It's about making sure that people survive. Because let us put the data in context. 85 globally at the moment, 80% of cases are asymptomatic, 15% of cases are unwell, and 5% are critical. It's to make sure that those 5% that are critical survive. And from those 5% who are critical, we know that it is showing that it's the elderly, people over 55 that are at risk of dying, people with comorbidities, hypertension, diabetes, cancer, sickle cell. Those are the people, renal failure. Those are the people that are at risk of dying. So it's an opportunity to look at our health system and make sure that, you know, people survive. Livelihoods you've talked about. So it's looking at now in terms of making decisions about opening up. And I talked more about the precision lockdowns and about being more clinical in the way that we roll out our public health response, and to make sure that people trust and keep trusting the advice that we're giving them. So making sure livelihoods are maintained is so critical. The other, I think, is around liberty. So some of the public health public health measures, we call them the PHSMs, the public health social measures, have an impact on liberty. You know, you can't associate up above a certain number, you can't go to the market, you can't go to school. So we need to make sure that in making those decisions, we use data, evidence, and we use a human lens approach. And also ensure that we're not militarizing our approach and interventions as well. So that is also very important. And that's where the guidance is coming in terms of from NCDC, from the various partners that are supporting, from the UN and so on, to understand the data more and to be more granular in the way that we advise, get the data. And I think the next stage is that these data should now move from the national level to the state level. So the commissioners, the state epidemiologists, and down to the local governments should understand their data. And this has an implication not only for now, but for the future, for other outbreaks. COVID-19 is here today. Other outbreaks will definitely come. So let the lessons we learn in improving our systems be essential to make sure that the outbreak that happens tomorrow, we will be better prepared and we can leverage what we have learned, just like we did for Ebola, so that we have moved the step with our response to COVID-19. And therefore, we can, in the long term, the longevity, the long term address. So I'll say the 4 L's, livelihoods, lives, liberty, and long term should be some of the 4 L's that we think about going forward. Thank you.
Okay, thank you very much. You spoke about precision lockdown. There can't be precision lockdown without data. So far, we're just doing a quick research on our states that we have on this panel. I note that Ekiti seems to have launched a GIS-based application. Honorable Commissioner Ekiti, as we round up this webinar, how has that improved your data collation process and decision-making process?
I didn't get you. Hello? I didn't get your question. Yes. What's the question?
I read somewhere that you have launched a GIS-based application.
Yes.
Okay. Is that helping to inform your decision making?
Yes. Okay. I'll answer the question. Basically, the GIS application that was launched is true because we have a research team, and our research team has started they are using the GIS to locate the households that we are going to pick for the sampling, to make sure the sampling is going to be internationally acceptable, whatever result. So the GIS is purposefully to pick the household where the sampling is going to be taken from, so we can have our analysis and our research result will be unbiased. So basically that's the reason for the GIS. It's not for treating, it's to do general surveillance, but that surveillance will be based on households, and the GIS will be what will be used to locate those households.
And that's very useful as it helps us to inform, do we lock down, do we just lock down certain local governments, do we, like Dr. Agoba said, do we just shelter in certain populations of people? Anyway, so just Dr. Yaya Kolade,
yes,
lives, livelihoods. It's a question that you have to answer all the time to Governor Fayebi, your governor, who says,
yes,
look, the Commissioner of Finance wants wants the states to be open. You are the Commissioner of Health. How do you manage such a tension? You are seeing number of cases rise up, God forbid, but here you have to make a judgment call to the governor. And the Commissioner of Finance is like, no, we have to open so that we can make more money. How do you navigate that? And the same question will go for Dr. Danja Katsina. So
okay.
Let
me be thank you very much for that question, Dr. Kumola. When in Ekiti State, His Excellency Dr. John Kayode Fayemi has always deferred to the medical experts. And every time we are in ESCO meeting or in a private meeting with him, with myself and my peers and some of the health officials, he deferred to us and asked questions. What do you think is going on at this time? And based on explanation, lives matters to him. And one thing I have really appreciated is that he listens to those advices. And the Commissioner for Finance have never given me any problem. I'll be lying if I said anybody bothered me on my advice. And when I tell him that this is what I think, he listens to professional advice, and that is what has been going on. Actually, I'm the chairman.
Thank you so much for that.
Yes, I'm the chairman that is heading the committee for religious activities that would decide when we are going to open those churches. And all the recommendations that is coming from my committee that I chair will be going to His Excellency. And his decision will be based on those recommendations. So I have no problem.
Thank you very much, Dr. Yakolade. I move to the Commissioner Health Katsina. You know, this is a live debate in your EXCO all the time. How do you manage this? Livelihoods.
Yeah, Doctor, other listeners, it's actually a very big debate, usually during the ESCO. But one important thing is that in Katsina State, we have representatives, 2 of them from the ESCO, that are the eyes and the ears of the ESCO. And they are part of the COVID-19 Task Force Committee of the state, headed by the Deputy Governor. And we have a fundraising committee also under the able leadership of His Excellency, the Deputy Governor. And the Governor of the state has given free hand to the committee to ensure that the funds and they utilize it in managing COVID-19. So whatever we are doing has been so transparent and then so smooth. We have never encountered any problem. And all the time during the ESCO committee, we do brief them on what has transpired during the sittings of the committee and the expenditures that has been incurred. That has never been.
Thank you very much, Dr. Danja. So I move to Kano. Kano, I would like to hear from you in terms of information, education, communication. A lot of people today do not believe that COVID-19 is real. And sometimes, in fact, the early phase of the pandemic, you know, some of the information we're hearing from a number of states, including Kano, was that no, COVID isn't real. What are the communication strategies that you have in place in Kano, Dr. Hussein?
Yes, COVID, especially at the beginning of the outbreak, we have a lot of naysayers. Remember, we had one of the viral videos that goes out from Kano is that COVID is not even true. But then how do we get out? This is the how. We engaged several strata of community. We used the traditional media, the social media, and also we engage a lot of stakeholders. We engage the traditional institutions, the religious institution, the various pressure groups, community-based organizations, and we approach them through their own means. You know, sometimes it's easier for you to get accepted if you use what people are more knowledgeable about and what they are used to. So we approach them, we ensure that we educate them on what COVID is, how it is transmitted, what are the preventive measures, and they became our champions. They became to propagate in mosques, in places of worship. You hear imams, pastors, clergies generally speaking about COVID, what to do to prevent that this is real. And this is gradually how we overcome this situation. And we also engage a lot of social media influencers, those that have real followership, and we sensitize them, we get them all the necessary information, and they became our champions. Just 2 days
Thank
ago,
you so much,
we
Dr.
a lot of
Husseini.
others.
Thank you. Thank you.
Thank you. You're
So
welcome.
I think we've had a very interesting discussion this afternoon, just like 2 weeks ago when we had a conversation with the states like Lagos, like Ogun, and Jigawa. Now we've heard from Kano, we've heard from Katsina, we've heard from Ekiti. And one thing is clear, several of the states are rising up to the occasion, deploying innovative strategies to support their citizens in their states. For instance, as we've heard from all of the three participants, they've actually ramped up their testing capabilities. They've used a all-hands-on-deck approach, pulled in necessary critical staff from facilities that are either private or even federal-owned facilities in their states. And this is the kind of collaboration that you really don't see within the Nigerian health system. And I think it's something that we need to begin to document. Healthcare workers at the front line are being innovatively dealt with. They're being given additional incentives. What we haven't heard so much is the availability of supplies, because at some point now, everybody is going to buy stuff from the same market. How do we ensure that we maintain a constant supply of PPEs, of reagents, of consumables to the front line? And I will charge colleagues at ACIOE, maybe that's one of the things we might need to look at in this series, to say how do we maintain supply chains to the front line, because everybody is buying from the same market. So on this point, I hand over to the CEO of ACIOE to give his closing remarks. It's been a pleasure having everyone on this call. Ekenem, over to you. Thank you.
Many thanks, Dr. Olumide. Thank you for the excellent moderation. If we're in public, we would have said a round of applause, but we are on a webinar, so we may have to maybe raise our hands just to give a round of applause for his excellent moderation. This has been a very enlightening discussion with great data, facts, and insights of what's really happening in some of the key states that we don't necessarily hear about sometimes, but we all know about Kano, but it's good to hear from Katsina and Ekiti, and also bringing Dr. Emmanuel Agogo to share his perspective on what he's seeing from the overall perspective. We want to definitely thank our distinguished panelists. We also want to thank all the attendees who took time to be here for the past hour and a half. To Dr. Olumide's point, he mentioned about supplies. It would interest you to know that one of our partners, I can't say the name of the company, but they've actually supplied Frontline essential supplies to all the frontline healthcare workers across the 36 states of Nigeria. They're actually present on the line. And so they have done supplies to Katsina, Kano, and Ekiti. So it's interesting to note that. I just want to end on this note by saying there are a couple of things that would appeal to our honorable guests, and especially our commissioners and the ES. One of the things that we want to definitely think about moving forward, I know you're working on this, is the importance of the health budget in the grand scheme of priorities of the state. The second being around data. Dr. Olumide talked about this earlier on. The third one being around telehealth. So we're in a system where people are afraid to go to hospitals and all these other places, and they may have symptoms. So this would be a good time to think about telehealth. The fourth one is around the fact of the other health there's a concern about the fact that other health, there are concerns about the fact that things like child spacing, things around HIV and some other core health areas may be ignored during this period. So I know some of the commissioners and the ES mentioned about some of the work they're doing there, but we'll appeal that they take a greater look at it so we don't have like a, quote unquote, a second impact or pandemic coming in the limelight. And the last one I would just say is our frontline healthcare workers remain essential to all that we're doing. So the importance of local production, my colleague Dwayne mentioned it earlier. One of the key things Morocco was able to do to address a lot of their concerns was around local production. So we'd like to encourage that all the states that are on this particular webinar and the other ones that may not be on the webinar should really think about scaling up local production of essential supplies, especially for the frontline healthcare workers, and also for people wearing masks in their particular states. Once again, on behalf of ACIOE Associates, we'd like to thank you for taking the time to be with us today. Our next webinar will be on the 25th of this month, which is next week. So once again, I want to give kudos to Amidele Odushote, who was the one behind a lot of it, and they were excellent ACIOE team, Doing, and the rest of them who did a lot of work behind the scenes in terms of making sure that all our guests were here on time and were able to give you some good information. Our apologies for the technical glitches earlier on. Thank you so much. And lastly, all the, saying this again, all the slides and the videos we sent to all the attendees. Thank you very much and have a wonderful day.
Thank you.
Thank you and goodbye.
Bye-bye.
Bye.
Thank you very much. Thank you.